Hello, 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 ladies and gentlemen. Tonight we are thinking about the biliary and pancreatic disorders, and this is the 10-minute lecture, the 10-minute review. When we are talking about cholecystitis, please remember that one approach to remembering the signs and symptoms associated with gallstones is the 5 F's. The 5 F's: fair, fat, or overweight. You are female, you are in fertile years, and you are over 40 years of age. Some of the risk factors for gallstones will include obesity or rapid weight loss, one or the other, weight loss surgery, eating large amounts of foods with saturated fats, pregnancy, and pregnancy is because of the elevated progesterone level. Some clinical manifestations of cholecystitis to think about is the palpable fullness of the right upper quadrant. And one of the hallmark signs, ladies and gentlemen, of cholecystitis is that positive Murphy sign, which is pain on palpation of the right upper quadrant upon deep inspiration. So the patient will breathe in deeply as we are pressing on that right upper quadrant, and they will be positive for pain. Jaundice, and this is because of the impaired bile flow. Please remember that the preferred method of intervention for gallstones is the laparoscopic surgery. The laparoscopic cholecystectomy is what it is called. If stones are present in the common bile duct, the surgeon may place a tube, which is a biliary drainage tube, into the common bile duct to monitor for bile drainage. So post-operative care of this T-tube requires assessment of the characteristics of this drainage, the color, the consistency, and the amount. When the patient, if they are taking care of this at home, is to be emptying this, and that would be when the bag is about half full to 2/3 full, and this is because any heavier than that, and the bag will begin to pull on that insertion site. And you or the patient, if they are taking care of this at home, needs to monitor their skin. So skin care is important. And even though the book discusses this, I have never had to do it. I've never instructed a patient or a family member to do it at home, and that would be to flush the tube as ordered. So some medical management of acute pancreatitis. Let's move on. Elevated BUN will indicate impaired kidney functioning, suggesting hypovolemia. So hypovolemia, that's just a fancy word for dehydration. Elevated AST levels will indicate drainage to the liver. Elevated ALT levels is indicative of a gallstone pancreatitis. And an elevated serum lipase is the most specific test for pancreatic issues because lipase is produced only by the pancreas. So when the lipase, when you see that is elevated in the patient's labs, then you will know that it is the pancreas. Decreased serum albumin will be related to inadequate nutrition whenever we are thinking about serum albumin for these disorders or disease processes. It is always related to nutrition. Some medications for acute pancreatitis. Medications used in treatment would include opioids and analgesics for pain, anticholinergics to decrease secretions, histamine blockers because we want to dry up those secretions as well, pancreatic enzymes because the pancreas is not working, so therefore we have to give it the lipase or the pancrease in order to help those nutrients to be absorbed, and if necessary, antibiotic therapy. Ladies and gentlemen, on page 1484, table 60.3, medications used in the treatment of acute pancreatitis, you will know that table. Chronic pancreatitis, moving on, the most common cause is heavy alcohol use. On page 1488, box 60.4, the causes of chronic pancreatitis. You will be familiar with that table. Patient education for chronic pancreatitis. The patient needs to try and avoid alcohol. This will exacerbate the dysfunction of the pancreas. And this is very, very difficult to do because please remember that there may be an underlying comorbidity of alcohol abuse. These pancreatic enzymes are not to be chewed. They are not to be broken up. They are meant to be swallowed whole. We can instruct them to try and limit fat in the diet, avoid intake of irritating foods or beverages, many times coffee, caffeine, anything caffeine related will increase gastric distress. And if necessary, because of these underlying comorbidities, we will refer them to support groups such as Alcoholics Anonymous or Al-Anon, as this is a progressive and irreversible disease. So taking care of the patient with pancreatic cancer, surgical management of pancreatic cancer, the stage of the cancer and the location of the tumor will determine whether surgical intervention is an option. So a doctor is going to do testing. He's going to look at the diagnostics. He is going to look at the size and the location of the tumor, and doctor is going to formulate that plan. Surgical resection is potentially curable. However, ladies and gentlemen, please remember, if there is lymph node involvement, generally the cancer is unresectable. Many patients may undergo surgery to relieve symptoms, and this is not a cure, but this may just be for palliative reasons. A celiac nerve block can be performed to decrease the pain associated with compression of the celiac nerves that are surrounding the aorta. An NG tube, and we will do an abdominal assessment. So post-operatively, patients who undergo these procedures should be monitored for exocrine insufficiency. And ladies and gentlemen, this is when, because of the lack of digestive enzymes, the patient is unable to properly digest food. So we call that syndrome exocrine insufficiency. And we are also going to monitor them for diabetes, because they may now become insulin dependent, because remember that pancreas is not working. In addition, ladies and gentlemen, patients who have an NG tube that has been placed by the surgeon, that NG tube is not to be manipulated by nursing, not in any event, not in any circumstance. On page 1491, there is a safety alert pertaining to that tube. Some nursing actions for pancreatic cancer. We will provide interventions, and one of the things that we will do is, for these patients, they need intravenous fluids. Hypovolemia occurs because of third spacing, because of fluid loss. So what happens is the fluid is essentially moving out of the circulatory system, and it is moving into the tissues. So because it is not in the circulatory system, your patient will appear dehydrated. So we need to replace those fluids, even with the third spacing. We are going to maintain NPO status if necessary, because the patient may not have GI function. So this patient is going to be NPO until their GI function returns. They, again, may have an NG tube to low suction. This is to decompress the stomach because of post-op distension. And again, this tube is never to be touched by nursing. You are simply going to maintain and monitor the tube. You will never manipulate that NG tube. NG tubes are placed by the surgeon. Manipulation can increase the risk of anastomotic breakdown, so the tube is going to be maintained by us. We are going to monitor it, but essentially the surgeon is responsible for that tube. And because of the pancreatic issues, if necessary, we are going to administer insulin. And as always, ladies and gentlemen, thank you again for your time and attention. And please remember to reach out with any questions, comments, or concerns. Thank you.